Okay, good afternoon, everybody. My PhD topic is improving outcomes in acute life-threatening emergencies. My name is Gergő Szabó. I'm an emergency physician working in an emergency department in Székesfehérvár and in 2 different pre-hospital ambulance services. My vision is provide the most appropriate care to all the patients treated in the acute phase, and the mission is demonstrate that scientific methods can be used to improve patient care. To achieve this, I've got 3 specific goals. The first one focusing on bedside ultrasound modality. The second one is to find the best infusion in diabetic ketoacidosis, and the third one is a retrospective study focusing on the transfusion. So my first systematic review and meta-analysis title is Point of Care Ultrasound Improves Clinical Outcomes in Patients with Acute Onset Dyspnoea. We know that when someone is admitted to the hospital with the acute onset dyspnoea, it can cause high 30-day mortality rate, and differential diagnosis, what we learned in the university, can cause often delayed treatment. The conventional approach to make the correct diagnosis when someone is treated with dyspnoea is inspection, auscultation, waiting for the results from the chest rate, or waiting for the results from the laboratory tests. But these methods are often time-consuming, and it may lengthen hospitalization. We know that point of care ultrasound, abbreviated PoCUS, can enhance early treatment, but the evidence was uncertain. So here is my PICO. We evaluated patients who was admitted with acute onset dyspnoea. In the intervention arm, we used the PoCUS. It is an ultrasound modality which is made by non radiologic expert, but an emergency physician or an intensivist or any kind of doctor. The control arm, we did not use the ultrasound modality, and I show my outcomes. So from more than 11,000 articles, 14 of them were suitable for data collection. And here is my primary outcome, time to diagnosis. We see that more than 1 hour time reduction could be achieved when we used PoCUS compared not to use PoCUS, which is clinically absolutely important and statistically also significant. In my second forest plot, you see time to treatment, which is again a very important question when we treat someone who is in a dyspnotic condition, and nearly half an hour time reduction could be achieved with the PoCUS, which is again important and also significant. And there's a judge question whether we can make a diagnosis quickly, whether these diagnosis and treatment appropriate or not. And with this slide, with this result, we can say that more than 2 times higher odds can receive a patient an appropriate treatment when we use the PoCUS compared to not use it. And we see an effect on the length of stay, especially in the intensive care unit. We can achieve more than 1 day time reduction, which is also important. So this result was published in previous October in a D1 journal, and here is a graphical abstract which we made, that using the PoCUS, it means smartphone size equipment. Usually, so when we use it, we can reduce time to diagnosis, time to treatment, we can decrease the length of stay, and improve the rate of appropriate treatment. My second project is a fluid resuscitation with balanced electrolyte solutions results in faster resolution of diabetic ketoacidosis than with 0.9% saline in adults. It's again a meta-analysis. We know that diabetic ketoacidosis requires more than 500,000 hospital days per year, and the fluid resuscitation is one of the cornerstones of early management. Guidelines recommend one kind of infusion that is called the saline, but it can cause hyperchloremic acidosis, and it can worsen the renal functions. In contrast, balanced electrolyte solutions, which contains less chloride ion but contain more potassium, So these balanced electrolyte solutions are more physiological, we suppose. So we evaluated the patients who is admitted with diabetic ketoacidosis. It's a condition when somewhere could be in a life-threatening condition with diabetes. So in the interventional, we use the balanced solutions, in the control, the saline. And I show you my outcomes from 7,000 articles, 10 were suitable for data collection. And the time to DKA resolution was our primary outcome. And we see when we use the balanced solutions, we can use more than 5 hours quicker resolution than compared to the saline, which is significant and also important in our daily practice. And there are some results about the biochemical changes during our treatment. After the resuscitation with these fluids, we see that chloride levels could be lower in the balanced solutions, although this result is statistically significant, but the clinical importance is questionable because the 4 millimole per liter is not a so huge amount. And it's also true for the sodium. So we see again a significant but disputable result that 1.4 millimole per liter mean difference. What is the meaningful clinical importance? And also bicarbonate level, the same matter. So we can sum up the results. We evaluated 10 studies, 7 RCTs and 3 observational studies, and it is the most comprehensive meta-analysis to date. But there are limitations, the low number of patients, and there were different DKA resolutions in the studies. So, but we can conclude some implications from practice that the main point is that you can shorten the time to DKA resolution. That is the main take-home message from that study, I suppose. So we submitted to a divan journal, but it's rejected. So we submitted again to another one, but no answer arrived yet. And my third project is planned to be a retrospective study. It is a working title, Pre-Hospital Red Blood Cell Transfusion in the Hungarian Air Ambulance. We know that injury is the leading cause of death in adults and children between the age of 1 and 44. And in major trauma, bleeding is one of the main causes of death. And results about the efficacy of pre-hospital red blood cell transfusion are controversial, and most of the data come from the military part of the treatment. So our study may add that with the helicopter team that is called the HAMS, Helicopter Emergency Medical Service, from 2019, 2 unit zero-negative red blood cell can be transported to the scene of the accident, and we can give it to the patients. That is the transfusion indicator and SOP in our company, so we can give blood if massive bleeding is suspected, and 2 other conditions. Blood pressure can only be maintained in the target range with fluid administration or vasopressor, or circulatory arrest happened within some definitions. So our PICO, so patients will be evaluated who are in massive or catastrophic bleeding. The vast majority of them suffered trauma. In the interventional, we plan to give 1 or 2 unit zero-negative red blood cell transfusion, plus fibrinogen, calcium, tranexaminide, acid, and so on. So this is available from 2019. In the control arm, we do not give transfusion. So that is the time period before 2019, because on that time, red blood cells were not available. It is planned to be 250 or 150 patients in both arms. And our primary outcome is planned to be mortality, but a short time of mortality, we are planning to evaluate the 24 hours, because long-term mortality is very depending on the treatment given in the hospital and not caused by pre-hospital transfusion. But of course, there are the secondary outcomes like the hemoglobin at admission, the transfusion in the first day. So these 3 projects what I'm working on, and I want to thank you for your attention with a quote from my professor that the diagnosis can wait, but cells cannot. Thank you.
Congratulations. Anyway, so can we go to the very first study first for explodes? Maybe one actually. Yeah, this one. So you're stating actually, and then you have, I think, good foundation, although I'm a little worried, asking this kind of questions because some of that mathematical. But you have actually 7 studies, showing one direction. And then there is one study, which is a kind of outliner on this, just looking the whole thing together. And in one study, it looks like that there is no difference in the time of diagnosis. And in other studies, just visually, you could see. And then your overall result shows this. So since we really look for the truth, is there any particular reason why in that one study they didn't find any difference?
There's a huge number of heterogeneity in these studies, and a lot of causes can be behind this. Only one, different ages were included. There was a study who evaluated infants, especially in the pediatric ICU. There are other studies who is evaluated older people. There are studies who focused on patients treated in the ICU. There is other study who is evaluated patients treated with the rapid response team. We use in Hungary a resuscitation team, and these some kind of not really confounding factors, but these could be the background of this 100% heterogeneity.
And it looks like that the higher the sample number is, the difference is the bigger. So what I see, so maybe this is a question of actually practice. So then because if there is only a small number of investigations, then they may not have that much experience with that. So therefore, actually on the PoCUS arm, actually, that is actually weaker than it should be.
Yes, and I didn't show you the study characteristic table, but we also discussed the level of practice who made the PoCUS. There were beginners and also experts. It's a not so difficult method to learn how to use PoCUS, but these differences could be influence our results, as we see in daily practice also, because residents perhaps not so accurate as an expert.
Can I ask the fellows first? Any questions? Yes, please.
Thank you. Thank you for the presentation too. I have 2 questions. First, and both regards your third project. My first question is that about the feasibility if your results shows that there is a significant high effect with the transfusion before the pre-hospital transfusion. Thank you. How feasible is how many null blood type available? So it would be feasible to manage.
So what will the implication for practice? Or
yes,
I don't really understand the question. That is the question. So what will be the next step when we publish the results? How will it influence the practice?
Is it feasible to get as many blood transfusions as it's needed?
Yes. So it is planned to be a retrospective study. So we have already treated these patients. The HAMS team has an own database, which exists from 2018. So from 2018 until 2091, and in some conditions until 2022, but I don't want to discuss the details. So from the control arm, we have all the patients who would be transfused if we would have the red blood cell on the helicopter, but on that time period we didn't have. So these patients' data we have already. And on the intervention arm, we have also those patients who were transfused from 2019 until the study we plan to close at the end of this August. So we have all these patients. The main question will, how can we receive the data from the hospitals where these patients were transported? That will be the main question, because these patients were transported usually in major trauma centers, so at least 15 or 20 hospitals will include in this study in our country. And so I'm working on the TÜKEB ethical approval, so it will be not an easy question, not an easy job to collect all data from these hospitals. And after that, the next step, so implication from practice, red blood cell in our country is only available in the helicopter. There are 7 helicopters in the countries which is working in the day shift. But there are other type of ambulance cars which can transport now red blood cell. But if we will see that we can reduce the mortality and other outcomes, will give a better condition for patients, we can try to expand the availability of red blood cell to the ambulance cars also, not just for the helicopters.
Thank you. I just don't know the magnitude that how much more blood will needed if this goes to the regular practice.
How much?
What is the magnitude of? I can't imagine.
Not so much.
Okay.
Blood, because
not so many.
No. From 2019 until today, we have transfused, I don't know exactly the correct number today, but 150 patients. And we usually give 2 units, so it means 300 red blood cell package is not so much.
Thank you very much. And sorry, I have a second question. Is how do you evaluate the patient before you decide to give or not transfusion?
How to evaluate to give or not?
Yes.
Or if the indication exists, so transfusion is indicated, it is written in our standard operation practice and in our guideline in the helicopter team, we give. So
okay, what is the definition of massive bleeding there? Or you need blood pressure?
No, massive bleeding is just a suspicion. We evaluate the blood pressure. So I can discuss you the details, but perhaps it's not so important whether it's a penetrating trauma or a head injury. There are different systolic blood pressures which are the targets. And this target range can be maintained with fluid administration or vasopressor. Or there are some cases, but it's a minority, when circulatory arrest happens within 10 minutes before the presence of the helicopter team. It means a traumatic cardiac arrest.
Okay, now I understand. Thank you very much.
We have to still the students, if possible, to 2 more parallel questions. One here and one before that.
I just wanted to reflect your question. Actually, want to use less blood transfusion with this, because if you do early goal-directed transfusions with these indications, we can prevent massive blood transfusions later in the hospital. So if we do that, do the pre-hospital therapy better, it will actually prevent us from using more blood, because these patients won't have that disrupted homeostasis and coagulation. So actually, I think that's the goal, and that's what seems like is happening actually in HAMS, that early pre-hospital blood transfusions are better altogether for the patients and altogether for the blood.
Thank you for the comment.
Yes.
Thanks, Gergő. My question also is about the third project. So, if I understand correctly, you are going to be using a historical cohort. So these are going to be, the control group is going to be those patients until 2019 who didn't receive blood transfusions.
Yes, you are right.
And then everyone who received a blood transfusion did so after 2019.
Yes.
So surely there are other things that have changed from the control group to the intervention group in the historical progression. So every time you're using a historical cohort, it introduces a lot of confounders. My question would be, in this case, why limit yourself to the same centers which are now transfusing blood, and rather not use other historical cohorts from other hospitals who are matched with propensity instead?
Sorry, but I don't really understand
So,
the second
let me,
part of your question.
okay, so basically you are using the control patients are coming from the same clinics where patients received interventions.
Yes.
But the intervention group and the control group theoretically, possibly, have underwent totally different healthcare systems. This is the assumption that you have to prove otherwise in your study design. So while you are tackling that challenge, convincing peer reviewers that the historical cohort actually matches up with the intervention cohort, why limit yourself to the exact same clinics where you take the intervention population from? Why not look at all of the registry in, for example, the Hungarian ambulance, all of the registry, and just do a propensity score matching instead?
So answering your first question, I don't think any major change was from 2018 until 2019. So I don't think we changed anything which can influence basically our results. And on your second question, it's not really understand or clear for me what could help a propensity matching, but we transport all those patients to the same hospitals. They are the centers in Hungary, but these centers did not change anything in their guidelines. So all those patients who would be transfused or who were transfused were transported to the same hospitals. So sorry, but I cannot really get the question.
Then we should discuss this later.
To keep going, but I think the question is valid. And then you answer, probably you want to answer that the protocol didn't change in other
Yes.
factors. If it changed, it has to be very clearly actually identified and discussed.
Okay?
But what kind of protocol of the transfusion?
No, the protocol how to handle those who get injured and then transported to the hospital.
Yes.
This is what you said, that this is very similar. I mean, now we believe you, but the reviewers may not believe you, so therefore you have to spell this out. You have to show the protocol.
Okay, we've got protocols.
I believe you, again.
Okay, thank you.
But when you go to a journal, when you really look for the real truth, I mean, these have to be actually considered. Questions?
Yeah, I will. I have a different problem.
Oh.
I understand what you're saying, and I agree. I actually agree with you and disagree with Channer a little bit, that it's easier to handle it within the system, even if there was a minor change and control for that in the analysis, than do a dubious propensity matching thing. So my main problem is your primary outcome. You said it's mortality, right?
Yes.
24-hour mortality. And you have something like 150-something patients.
Yes, in both arms, discontinuity.
Yeah, but the thing is that mortality is not very easy to analyze, and you need a lot of data to find minor differences. And you have a lot of things affecting mortality here, from the type of injury, there are a lot of factors here. So it's not just the transfusion, right?
Okay, but we do not make subgroups based on the type of injuries. And
yeah, but that's affecting mortality. So there's a lot of noise, and you want one signal, right? But there's a lot of noise surrounding that signal. So for a statistician to be able to measure that signal, you need a lot of data so I can control for the noise. And 150 versus 150 is not a lot of data when it comes to binary variables like mortality.
Okay.
So I would definitely think about something that is correlated to mortality but easier to measure and control for. I don't know what it is. I'm not an ER doctor, but there could be some variables. I don't know. How stable is the blood pressure? How stable is whatever? Think about it. But I'm trying to avoid you being disappointed in the results.
Sorry for answering you, but we choose this outcome because it was published in best journals like JAMA, New England Journal of Medicine, from the same conception, but not with red blood cell, but fresh froze plasma. And they use mortality as a primary outcome.
I completely understand. I'm just saying that 150 versus 150 in the two arms is not going to be enough to do mortality. That's my problem.
Okay.
Not mortality itself. Of course, it's a problem, but from
The low number of patients.
Yeah, that if you have if it's not a huge effect that you're putting in with the novel treatment, then it's going to be really tricky to find that signal.
So what was the sample size in those studies? Because this is a crucial point.
Yes, I would say between 100 and 1,000. So more than this.
And I'm presuming that they had more luck with the 1,000 patients than with the 100 patients.
Okay. Okay, yes, I got it.
Another thing, with your first study that is already published, and I'm again criticizing, well, no, not criticizing, I'm just asking questions here. If I understand well, you have a new gadget, basically. I'm trying to translate it to my language. You have a new gadget that is quicker, right?
Yes.
Quicker in diagnosis. And you show that it's quicker in diagnosis and the time to treat, well, it is quicker in some cases with the diagnosis, but in the same time, it's quicker for all cases to treatment. Time to treatment was quicker.
Yes.
So where did that extra time come from? I mean, if the gadget helps you diagnose quicker, how did some papers miss treating quicker, or how did all papers be able to treat quicker but not be able to diagnose quicker?
Yes,
I don't understand.
That's an absolutely judge question.
There's something fishy going on.
Time to diagnosis was the most often cited outcome from the articles, and the time to treatment was a separate outcome in all those patients. I don't know, 5 of them evaluated them.
That's what I thought.
Yeah.
Okay.
But that's a judge question.
And the other thing, and this is just for future presentations, if you go back to that forest plot, just a quick guideline of what to answer. You quote that there's a high heterogeneity. Yeah, of course. But the main source of this heterogeneity is the fact that you're measuring something that is in time. And the time variables are not normally distributed. And these models are designed for outcomes that are trying to catch normal distribution.
Okay.
So simply disregard heterogeneity in this case. A, B, somehow we need to transform the data so we can assess that. Just look at the means. Like you have 2,683 versus 2,600 something mean minutes difference, right? If in one case you have 21 minutes versus 19 minutes or something like that, or 60 minutes and 40 minutes, yeah, sorry, I was looking at the patient numbers. But if you have an average of 40 versus 60, or an average 17 versus 104, of course the difference between the two will be big. It cannot, if something takes longer, then the difference between the groups can be bigger.
Okay.
And if it's short, so that's the main reason here. Okay, so it's not really true heterogeneity. We don't really know that.
Okay, it's a statistical heterogeneity.
It's a technical. Technically, we cannot measure heterogeneity in this case. That's what I'm trying to say.
Okay, thank you.
Okay.
So even the jury is learning it.
So if I may extend, and I'll declare bias, because I'm a believer in PoCUS. I do it for, I will not say how many years. Okay, now here I would also like to comment this particular forest plot. You have now the observational studies, and you have PoCUS 2,683 patients in the PoCUS and control arm. Is that
Yes,
correct?
From the Zanabati article.
Yes. Is that correct? So one patient was simultaneously in PoCUS and control arm.
Yes, but it was so it was a question during our data collection, but these two arms could be evaluated separately.
No, I know the study. I showed it always. It was published in Chest in 2017. So they actually had 2,683 patients in, and they have separated then the patients in whom they have used that or not. So I don't think that these numbers are correct. And the second comment, if you have now the random effect model, and you see that you have one observational study with 2,600 patients, and the other two are like 10% of that. But the overall effect is skewed to the right direction. I don't believe that's true. It's impossible. You see, you have 10 times more patients with huge effect, and the overall effect is non-significant. I don't believe that. And I ask statistician for the help here.
I will help. The thing is, there are two ways of looking at it. One from the weighing, how much weight one study gets in a meta-analysis. And in random models, it's a function of patients or sample size, or the total number of patients, and the function of how far it is from the others. So if you see that the weight of these studies are pretty equal all around, that's just the nature of random studies. So it's equally weighed, hence it's balanced, it's more balanced. The other thing I would definitely do in this case is, because I absolutely agree that it's very strange that the patient numbers are equal. So this is, it's just that they're not propensity matched, right?
No.
Okay, and the Corzini is not propensity matched?
No, I don't really remember, but I don't think.
They just happen to have 124 patients in both.
No. The first study had 2,683 patients in observational cohort. And here they are presented as PoCUS arm and control arm. That was my question.
Okay. Now I understand. Then it is, and then we have to look into it, because, of course, total patient number plays a role in the model. So if you add 2,683 in both arms, then
No, it's not in both arms.
I understand, but if the model was created as if it was in both arms, then the model is wrong.
I don't know to change. Okay.
I don't think it's going to change the overall result that much. It's just incorrect.
Because if I am, as a clinician, interpret this time to diagnosis, then I'm not sure whether it helps, but I know it helps, because I have the largest study that showed that. So, here, from the statistical point of view, it's not something that would help me from observational studies, because it crosses the interval. Now, there is one, and most of the studies in this meta-analysis had time to diagnosis as something you could analyze. The rest had far less patients that could you analyze. But there is one peculiarity. So saying that PoCUS is helpful in time to diagnosis, I have the paper here, so I can cite what you wrote. So it's helpful in time to diagnosis, it's helpful in time to treatment, it's helpful in reducing length of stay, all primary outcomes, but it's not helpful in hospital mortality, 30-day readmission rate. So we are doing something that is on time, proper, but not having the clinical effect. What is your interpretation of that?
It depends on how we evaluate clinical effect.
I've told you, in hospital mortality, 30-day readmission rate.
Okay, that is the hardest clinical effect, but there are
No, it's not. In hospital mortality, the other is soft. 30-day readmission rate is soft endpoint.
As I feel in an overcrowded emergency room, when we need a quick and appropriate diagnosis, this modality is absolutely useful. I feel it's a very important outcome.
I know, but your meta-analysis doesn't show that. So how do you interpret that?
Okay, we evaluated in another way what are primary and secondary outcomes.
Okay, let me put it another way. Could following things play a role? For PoCUS, I believe this should be moved to ambulance. Most of the studies you are having here is emergency room or ICU.
ICU, yes.
Yeah. There are studies showing that using point of care ultrasound in ambulance, so that is from the field to the hospital, gives you a diagnosis. There is one study from Slovenia, I can share that with you. So could that play a role? Then second thing, PoCUS is a mixed bag. You included studies that did lung and heart, that did abdomen.
Yes.
So could that play a role? And the third one, you are here saying that you analyze you are better than previous meta-analysis because you applied the broader definition of dyspnea, disregarding the cause of dyspnea. Could PoCUS be particularly helpful in patients with cardiac cause of dyspnea, lung cause of dyspnea, or any other cause of dyspnea? Maybe these are additional ideas to pinpoint in which setting, by whom, and for which patient this is most useful. And maybe then you would have the answer about the mortality effects and things like that. So just a suggestion for the next analysis.
Thank you.
And maybe a quick one for diabetic ketoacidosis. Did you look into the etiology, cause of diabetic ketoacidosis? Because there are several causes
The causes of excessive
of diabetic ketoacidosis. There are several causes.
Yes.
And one that is very, very important recently are SGLT2 inhibitors. They can induce diabetic ketoacidosis. So did you look into the etiology if there are differences between the therapies?
No, we didn't.
That could potentially be relevant. And then infection and drug treatment, so whatever. So maybe that could be helpful.
Thank you.